Good afternoon, students. Today is Tuesday, 16 March 2021. We're running behind, but today's lecture will bring us up to spring break. When we return from spring break, we will get started on the next essay, which is by John Hardwig. The title is There a Duty to Die? I have posted the article by Hardwig already. So try to find some time before you watch the next video next week to read, let's say, half of Hardwig. We're going to spend 3 full days on that essay. So your next lecture will be around Tuesday, 23 March, which is a week from today or perhaps a day after that. Okay? So this is our second and final lecture on Raanan Gillon. And we've covered about half of it. Today I'd like to finish it up. Remember now, for Gillon, there are 4 prima facie principles of biomedical ethics. In the order in which he discusses them, they are respect for autonomy, beneficence, non-maleficence, and justice. Now, the order in which he presents them does not indicate their importance or their priority. He could have discussed them in any order. It wouldn't matter. So we're just taking them in the same order he does. So we've already discussed the principle of respect for autonomy, and we've looked at some of its implications. For example, a doctor should keep appointments, be on time for appointments, and so forth. Let's take up the topic now of beneficence. I have a handout on beneficence. It's been posted on Canvas for you to read and think about. The main thrust of that handout is to distinguish between beneficence and benevolence. Both of them start with the prefix B-E-N-E, which means good. The difference is that benevolence is a character trait. A benevolent person is a person who is motivated to do good. And that's a good thing, right? People who are motivated to do good for others are good people to that extent. Beneficence is the actual doing of good. So we need to ask which of those is being implied by the principle of beneficence. It's the latter. The principle of beneficence says that you have an obligation to do good, whether you're motivated to do good or not. You've got to act in that way. You've got to find a way to do good for others. That's one of the duties of a physician or a nurse or any other healthcare provider. Now, most of the time, people who are benevolent end up doing beneficent things. Because you're motivated to do good, you end up doing good, right? That's what motivates you to act. And by the same token, a malevolent person, a person who's motivated to do bad or ill, most of the time a malevolent person will end up doing maleficent things, will actually do bad or evil or harm. But not always. Sometimes people who are benevolent end up making things worse because they miscalculated or they made a mistake somehow in their actions. They were well-meaning, right, but they didn't end up doing any good. We sometimes call people like that do-gooders. Do-gooders are well-motivated and well-meaning and well-intentioned, but they don't always succeed in doing good things. They end up mucking things up, messing things up, making things worse. And by the same token, a malevolent person who is motivated to do evil may end up through accident or miscalculation. A malevolent person could end up doing good instead of bad. So don't confuse the disposition to do good with the actual doing of good. The principle of beneficence says you must do good. It says nothing at all about what your motivation for doing good happens to be. Here's what Gillon says about beneficence. He says on page 185 of his essay, he says, the traditional Hippocratic moral obligation of medicine is to provide net medical benefit to patients with minimal harm. That is, beneficence with non-maleficence. So it's a twofold obligation. In fact, we're now combining two principles. We're combining beneficence and non-maleficence. Remember, I told you the other day that Gillon treats those two separate principles in one section of his book or of his article. Okay, but really they're separate. And what he's saying is that a doctor has both of those obligations. First of all, do no harm. That's non-maleficence. And secondly, do as much good as you can. Bring about as much net benefit as you can in the course of your medical practice. Now, here are some implications of the principles of beneficence and non-maleficence. These are some of the, what Gillon calls subsidiary obligations. Okay, number one, a physician, according to Gillon, has an obligation to engage in, quote, rigorous and effective education and training both before and during our professional lives, unquote. So one way to do good and avoid doing harm to your patients is to stay educated. Make sure that once you become a doctor, you continue to learn. Keep up with the literature and the latest research to find out which drugs are effective and safe for which illnesses or diseases. Make sure you keep up with the latest surgical techniques if you're a surgeon, and so on. Just as lawyers are expected to stay abreast of the law and keep up with the latest legal developments, doctors are expected to keep abreast of the latest developments in medicine and keep up with medical developments. And that's part of what it means for a doctor to be beneficent. That's part of your duty in doing good. You can't do as much good as possible if you're ignorant of the latest research in your field. Okay? In the law, this is called mandatory continuing legal education. I don't know whether doctors call it that, but that's what Gillon is suggesting. He's suggesting that you voluntarily keep up with the latest developments, whether particular medical associations or boards require that doctors attend seminars and so on, I'm not sure. But lawyers are, I know that. Okay, next subsidiary obligation. There's a connection between beneficence and autonomy, and here it is. In order to do good for your patients, you have to understand their conception of the good. People's conceptions of the good differ. Your conception of the good life may differ from mine. For me, the good life may be a life of action and, to some extent, contemplation. Other people may not attach much value to the active life. They want a sedentary, studious, bookwormish life. So, in order for a doctor to truly do good for his or her patients, the doctor must take pains to find out what that patient's understanding of the good is. Here's how Gillon describes this. He says, for example, a mastectomy may constitute a prospective net benefit for one woman with breast cancer, while for another, the destruction of an aspect of her feminine identity may be so harmful that it cannot be outweighed even by the prospect of an extended life expectancy. So imagine two women who have very different attitudes toward loss of a breast or both breasts. The doctor who wants to benefit a woman must determine whether she has this attitude toward loss of her breast or this other attitude, right? Because the women in question have different conceptions of their own good, a doctor who wants to promote her good must know what her conception is. And that means taking her beliefs and values into account. It means respecting her autonomy. She gets to decide what's valuable, not the doctor. Okay? So if you're truly concerned to maximize benefit, then you have to pay attention to your patient's autonomy and how they understand their own good. A third subsidiary obligation is Doctors don't always know at the time they act what the outcome will be. So doctors are always factoring in probabilities, or what we might call risks. A risk is simply a probability of a bad result occurring. Okay, some procedures are more risky than others. That just means the probability of a bad outcome is higher for them. So probabilities vary. Some outcomes have a low probability of occurring. Some outcomes have a high probability. It's really a scale. I hope you can see a scale going from high probability on this end to low probability on this other end. And then there's everything in between. So here's how Gillon describes this. He says, quote, clearly, a low probability of a great harm, such as death or severe disability, is of less moral importance in the context of non-maleficence than is a high probability of such harm. Okay, there's another half of that, but let's stop and discuss that one. A doctor under the principle of non-maleficence has a duty not to do harm, and the doctor must therefore take probabilities into account. How likely is it that if I do X, I will be harming the patient? If the probability is high, then I may decide that it's not worth the risk, and I may choose not to perform that action. If the probability is low, it may be worth taking that risk. So if your goal is to avoid harm, you should be attentive to the probabilities of harm occurring should you do this or some other thing. Now here's the second part. Gillon says a high probability of great benefit, such as cure of a life-threatening disease, is of more moral importance in the context of beneficence than is a low probability of such benefit. So if your goal is to do good, in other words, if we're talking about the principle of beneficence, then the higher the probability of good occurring, the more likely you will be to perform that act. If the probability of good coming about is low, then the probability, then you will probably not want to perform that act, especially if there are risks involved. So always take risks and probabilities into account if you're acting in accordance with the principle of beneficence and the principle of non-maleficence. And that complicates things, doesn't it? It would be nice if the outcomes of our actions were always certain, but they're not. So we have to factor in probabilities. Okay, the next item on the list of subsidiary obligations has to do with medical research. A doctor may want to engage in medical research in addition to practicing and treating patients. And even if a doctor does not engage in medical research, as we saw earlier, the doctor must stay abreast of the latest research in his or her field or specialty. Medical research provides useful information to a doctor of many sorts. It informs the doctor of the risks of certain procedures and the benefits. So probabilities are understood better through staying abreast of the research, and also procedures and techniques, treatments, forms of treatment, therapy. So if your goal is to do good as a doctor or nurse, and of course that is one of your duties, then you need to stay abreast of the latest research, unless you can conduct the research on your own. Okay, the next item on the list is empowerment. Now this is interesting because according to Gillon, doctors have an obligation to empower their patients. And nurses would have this too. All healthcare providers or professionals would have an obligation to empower their patients. And what does that mean in particular? According to Gillon, it means, quote, doing things to help patients and clients to be more in control of their health and health care. So the doctor wants the patient to be involved in his or her treatment. And to do that, the doctor will try to empower the patient, make the patient feel confident, try to explain to the patient the importance of taking medications on time and in the proper dosages, make the patient feel empowered or in control. That's another word for empowered. Make the patient feel as though he or she, to a large extent, can control the outcomes of treatment, of courses of treatment. Now, Gillon says that this particular obligation is a combination of respect for the patient's autonomy and beneficence. So here's a case where two principles work together to produce the same outcome, empowerment. Now, I'd like to read just a little bit of Gillon from time to time. I'm reading now from page 185 of my essay, and it's in the left column near the bottom. So let's read and discuss this. Gillon says, to exercise respect for autonomy, healthcare workers must be able to communicate well with their patients and clients. Good communication requires, most importantly, listening, and not just with the ears, as well as telling, and not just with the lips or a word processor, and is usually necessary for giving patients adequate information about any proposed intervention, and for finding out whether patients want that intervention. So that goes back to a point we made the other day. Communication is essential in the practice of medicine. I actually meant to read another paragraph just now. There's no harm in rereading that same paragraph or part of it. Let's shift over to column 2. I want to read a shorter paragraph on empowerment. Sorry about that. One moral concept that in recent years has become popular in healthcare is that of empowerment. That is, doing things to help patients and clients to be more in control of their health and healthcare. Now that's the part I quoted a moment ago. Here's the new part. Sometimes empowerment is even proposed as a new moral obligation. On reflection, I think that empowerment is, however, essentially an action that combines the two moral obligations of beneficence, or doing good, and respect for autonomy to help patients in ways that not only respect but also enhance their autonomy. So one way for a doctor to actually promote the autonomy of his or her patients is to empower them, right? To give them the sense that they can and should make decisions along the way as part of their treatment, as part of getting well or recovering from whatever illness or injury they've been afflicted with. Now we're just about done with this section. We're still talking about subsidiary obligations. That means obligations that flow from the principle of beneficence or the principle of non-maleficence. Let's focus in on beneficence for a moment. What are the various ways you can do good for somebody? Well, there are a number of them, at least 4. The first way to do good for someone is to prevent harm to them. So suppose, for example, I'm out on the trail walking, sightseeing, bird watching, whatever I'm doing, and I see another person some distance ahead of me on the trail, and I happen to notice that a big tree is in the process of falling slowly, right? It has been uprooted and it's creaking and starting to fall. The person ahead of me may not notice that the tree is falling. So one way I can prevent great harm to that person is by yelling, "Look out, a tree is falling." The person may then look up, see the tree, and run out of the way. And with any luck, the person will escape injury or death. So one way to do good for someone, as I just did for that other hiker, is to prevent harm to them, harm that would otherwise befall them. So what does it mean to prevent something? It means I did something, and as a result of my doing it, someone who would otherwise have been harmed was not harmed. So if your goal is to be beneficent, then find ways to prevent harm to others. And doctors should certainly take that to heart. Doctors know, if a doctor knows that a particular patient is at risk of some harm in taking a certain drug or engaging in a course of action, the doctor should advise the patient not to do it. For example, suppose the patient has a particular ailment that the doctor knows could cause serious harm if the patient were to engage in vigorous exercise. The doctor will advise the patient not to engage in that vigorous exercise on the ground that if you do, you may, if you're taking this drug and you engage in vigorous exercise, you could have a heart attack or something terrible like that. So the doctor is trying to do good for the patient by preventing harm to the patient. Okay, so that's the first of 4. If your goal is to do good, then try to find ways to prevent harm. Secondly, if the harm has already occurred, which means it's too late for you to prevent it, you can remove it somehow. The person has been harmed, and maybe there's something you can do to remove the harm. Let's use the same tree example. Suppose the tree has actually fallen and has landed on the person's leg. So the person is trapped. And of course, the leg may be seriously injured, broken even, but the patient can't get away. If you do nothing, the patient may die, may die of exposure, depending on how isolated the trail is, or the person may lose blood and eventually die from that. So it may be that you can do something to get that tree off the person's leg. So it's too late to prevent harm, but maybe you can remove the harm in some way by getting the tree off and getting the person to a hospital for treatment. Okay, we can call that harm removal or harm elimination. And that's a second way to do good for someone. Third, it may not be possible either to prevent the harm from occurring or to remove the harm once it occurs, but it may be possible for you to alleviate the harm. Now, pain is a harm, I hope you agree. If you're in a condition of pain, that's a harm to you for as long as the pain lasts. Now, suppose someone has been injured and is in great pain. If I happen to have a pain reliever on me, I can give it to the injured person, and while that may not remove the pain altogether, it may make the pain tolerable, at least until the person gets adequate medical treatment. So we can think of that as pain relief or pain alleviation. Notice that's different from the other two, isn't it? Preventing pain means doing something to keep it, preventing harm means doing something to prevent it from occurring at all. Removing harm means it's too late to prevent it, but there's something you can do to remove it or stop it from continuing to harm. The third one is different from both of those, right? In this case, it's too late to prevent the harm, and I cannot remove it altogether because I can't get rid of all the pain, let's say, but I may be able to reduce the amount of harm, or in this case, pain, by providing the pain relief. So those are 3 analytically distinct ways of doing good. The fourth way of doing good is to confer a benefit on somebody. So this is not a case where someone has been harmed and you're removing it or relieving it. It's not harm prevention. What you're doing is you're finding ways to make people happier or to improve people's welfare. Right? That's a pure benefit. Think of that as, in fact, let me explain all 4 of these forms of beneficence with a simple baseline metaphor. Let my hand represent the person's baseline. This is the normal state of affairs for the person. Anything above it means the person is better off, and anything below the baseline means the person is worse off. Okay, think of that as the baseline or normal state of affairs. What does it mean to prevent harm? It means acting so that the person doesn't fall below the baseline, doing something to keep the person from going below the baseline. What would removing harm amount to? Removing harm means the person has already fallen below the baseline, the tree has already landed on his or her leg, and you can bring the person back up to his or her baseline. That's called removing harm. Alleviating harm means the person has already been harmed, and it may be impossible for you to bring that person back up to the baseline, But what if you can bring that person partway back? That's a good thing, right? That's an improvement in the person's condition. That means you're benefiting the person. Okay, what would conferring a benefit be? Well, here's the baseline. Conferring a benefit means you're doing something to make that person put that person above the baseline. So what if you, for example, what if you have neighbors who have children? The children are, let us suppose, adequately fed and clothed and housed and so on. All of their essential needs are being satisfied. But suppose the family is of modest means and the children really have very little joy in their lives. They don't have many playthings like bicycles or swing sets. If you're in a position to do so, you may want to donate some toys to the kids. You may offer to have a swing set installed in their backyard, or offer to provide a bicycle or two for the kids to play with. That would be a way of benefiting the kids. It would make them happy. Remember, happiness is a benefit to people. Better to be happy than not to be happy. More happiness is better than less happiness. So that would be a pure benefit, a pure conferral of a benefit. You're looking around for ways to make people happier than they already are. Okay, now I could easily ask you exam questions about that because it's very cut and dried. Let me repeat it quickly this time. There are at least 4 ways to confer a benefit on someone and therefore fulfill your duty of beneficence. First is preventing harm. Second is removing harm that has already occurred. Third is reducing the amount of harm that's already occurred. And fourth is conferring a pure benefit on someone. So the principle of beneficence in medicine tells doctors and nurses and others to do good in as many of these ways as they can. Okay? Be a good doer. Don't be a do-gooder. Be a good doer. Now that may seem silly, and someone who hasn't been paying attention would say, what's the difference? Do-gooder, good doer? There's a big difference. If you look up the word do-gooder in a dictionary, you'll see that it has a negative connotation. A do-gooder, by definition, is someone who, while well-motivated, well-intentioned, well-meaning, benevolent, actually mucks things up and sometimes makes them worse than they were. So don't be a do-gooder. Don't get involved in other people's affairs unless you know full well that you can improve them, because you may be more likely to make them worse than to make them better. So don't be a do-gooder. But you should be a good doer, because a good doer is a beneficent person. Beneficence means doing good. So a do-gooder is bad, a good doer is good. And partly it's just that the term do-gooder has acquired a negative connotation. There was no necessity for that, but I think we needed a word in our language to describe people who mean well but end up making things worse. And it just so happens that the term do-gooder was chosen for that purpose. So all I'm saying is, given the meaning of the term, don't be that. Don't be a do-gooder. But if I coin a new term, and I think I coined this term, I've never seen this term anywhere. I thought of it the other day when I was doing lecture notes, actually, revising my lecture notes. I thought this would be an appropriate way to describe beneficence, right? Beneficent people are good doers. Okay, so let's move on to the next topic, which is justice. And when we're done with that, we'll talk a little bit about scope, because the title of Gillon's essay is as follows: Medical Ethics, 4 principles plus attention to scope. So we need to finish up the 4 principles by discussing justice, and then we'll talk about this thing called scope, and then we'll be done with Gillon. Okay, let's talk about justice. Now, the word justice has a long history, and many people mean different things by that word. Aristotle meant by justice giving people their due. And what he meant by that is treating likes alike and unlikes differently. And when you treat unlikes differently, you should treat them differently in proportion to their differences. So if someone has done well, has acted well, that person deserves reward for it. A person who acts poorly, who breaks the rules, for example, deserves punishment for that. So what people deserve depends on their own actions. And that's why justice is backward looking. Justice requires that we look back in time and see who did what and what their motives were when they acted. And then we respond to their actions accordingly and in proportion to their merit. So people who do great good deserve great reward. People who don't do only a small amount of good deserve small reward. People who do great evil deserve great punishment. People who do only a small amount of evil deserve light punishment, less severe punishment. So for Aristotle, justice had to do with allocating rewards and punishments in accordance with people's desert or merit. Also, when you're distributing scarce goods and bads, you should distribute them fairly and justly. And that means you should distribute them in accordance with the deserts of the people in question. So justice has really two faces. We distribute in accordance with people's own actions, and we don't even need to take anyone else into account when we do that. That's called retributive justice. And by the way, I have a handout on justice posted on Canvas, and it covers what I'm now talking about, plus more. So read it carefully. I may ask questions about it on the exam. So justice has two types. Retributive justice has to do with giving people what they deserve based on their own behavior. And it focuses not on other people and what they're doing, but only on the person in question. Distributive justice, as the name implies, has to do with distributing things like wealth, income, opportunity, and also bad things. How should taxes be apportioned and distributed among people? Should the people who earn the most pay a higher rate of taxes than people who earn less? What about the burden of military service? If and when we have another draft, military draft, how should it be set up? Should every person between a certain age and another age have an obligation to serve? Are there going to be any exceptions or exemptions for certain people? Should people who are attending college or graduate school or professional school get an exemption for military service? And if so, why? So distributive justice has to do with how we distribute the good things in life, like wealth and income and opportunity, but also the bad things, taxation, military service, and doing dirty jobs. Right? Dirty, dangerous jobs must get done. How are they to be distributed? Should we reward people who have to do jobs like that with higher pay, things like that? So distributive justice is a big field in philosophy, in ethics, and it has to do with how things are distributed fairly and justly. Now, what is Gillon's understanding of justice, and how does he apply it to healthcare or medicine? He says, justice is, quote, the moral obligation to act on the basis of fair adjudication between competing claims. So he's using the word fair as a synonym for just. Justice requires justice, just adjudication. It requires fair adjudication. What is adjudication? You may notice it has the root J-U-D in it, adjudication. That means judging, making judgments. So when we make judgments in the practice of medicine or in everyday life, we often are making judgments that involve competing claims. So you've got children who are fighting over something, and the parent must step in and adjudicate the conflict and find out, first of all, find out the facts, right? Whose object is it? To whom does it belong? Who has an entitlement to it? And then Why are they fighting about it? Has somebody tried to take it away from the rightful owner? Has someone damaged it and caused a squabble or a conflict? So justice, in one sense, involves adjudicating competing claims between people or principles, and it must be done in a fair way. So Gillon says there are at least three components or categories of justice. Here they are. The first one he calls distributive justice, and he says it involves fair distribution of scarce resources, the kind of thing I was just talking about when we talked about distributing the tax burden or the burden of military service, or the distribution of good things like like wealth and income and opportunity and healthcare. The second component or category of justice is what Gillon calls rights-based justice, and it is respect for people's rights. So justice, in one understanding of the term, means finding out what people's rights are and respecting them. So don't disrespect people's rights. If you have a right to speak, then I should respect that. And that means things like not trying to silence you or censor you, not trying to deplatform you or prevent you from speaking in some way. So respect people's rights, whatever they may be. Rights are valuable things. We all value the rights we have. We're jealous of them. We don't want them to be interfered with, infringed, violated, either by other individuals or by agents of government. So what Gillon is saying is if your patients have rights, you must respect them. That's part of justice. Third is what Gillon calls legal justice. This is respect for morally acceptable laws. So a doctor must work within the framework of law. Doctors aren't to be scofflaws or lawbreakers or outlaws. A doctor, like any other citizen, must obey the law. So the doctor must understand what the laws are on the questions he or she confronts on a daily basis and obey those laws. Show respect for morally acceptable laws. Now, there's one word in that that's crucial, and you can probably guess what it is: morally. It says respect for morally acceptable laws. Actually, two words: morally acceptable. It doesn't say respect for laws per se. It says respect for morally acceptable laws. So what Gillon is doing is he's building in an escape clause. If a doctor sincerely and conscientiously believes that a particular law is morally unacceptable, the doctor may choose to disobey it. In the great American tradition of civil disobedience, a tradition that goes back to Henry David Thoreau in the 19th century, that includes people like Martin Luther King Jr. in the mid-20th century. It also includes non-Americans, Mahatma Gandhi, for example, one of the great proponents of nonviolent civil disobedience. I'm sure that Gillon would say, in keeping with Gandhi and Martin Luther King Jr., that if a doctor or nurse chooses to disobey a law on the grounds that it's morally unacceptable or unjust, that medical professional must be prepared to take the punishment that's prescribed by the law. And that's what Martin Luther King Jr. advocated, as you probably know. When he and his followers broke the laws in the South, laws that they sincerely believed to be unjust, they went off to jail. They were arrested as they expected to be. They did not resist arrest. They went voluntarily to jail and they followed the law. If the law allowed them to be bailed out of jail and they were able to bail themselves out, they took advantage of that. But at no point did they try to escape apprehension. At no point did they resist arrest. And if they were punished in accordance with the law, they accepted it. So I'm sure Gillon would agree with all that. I don't think he's advocating that you break the law and then try to escape punishment, right? why would King require that you accept punishment? It's because that shows your respect for the law. Right? The law is valid. It may be unjust, but you should still have respect for it anyway. And that shows other people that you're not one of those lawbreakers who's trying to avoid punishment, that you're doing it for selfish reasons. That you're not doing it for selfish reasons, King said. You're doing it because you sincerely believe it's unjust, and laws that are unjust need to be disobeyed, and with any luck, they will be repealed, taken off the books. The whole point of taking punishment is to start a dialogue with the powers in society, right? With the authorities, in the hope that they will see your side of the argument and willingly change the laws. You're trying to persuade them that their own laws are unjust, in the hope that they will then repeal them and make the legal system as a whole more just. Okay, so let's try to implement the principle of justice in the context of medicine. This won't take long. I just have a few things to say, and then we'll move on to scope. According to Gillon, there are 4 perspectives that a doctor might take on justice. First of all, you can take justice into account in your personal decision making, the decisions you make as an individual, as a person. Secondly, you can look at justice from the perspective of your organization. If you're a doctor, you are part of an organization, whether it's a private practice or perhaps you work for the government or a private industry, a private corporation. So you can look at justice from the point of view of whatever organization you happen to work for or be a member of. You can also look at justice from the point of view of your profession as a doctor or as a nurse. You can look at justice from the point of view of the code of ethics of the American Medical Association, for example, which is a professional organization closed off to members who are not doctors. And you can also look at justice from a societal point of view. So notice 4 different points of view or perspectives, and they get larger. You start off with the individual, and then you go to the organization of which you are a member, which includes a number of individuals. And then you go to the profession as a whole, which is a group of organizations and individuals. And then you go even further out to the society as a whole. And in a moment, we're going to ask whether there might be such a thing as global justice, which is even larger than societal justice. So justice is manifold. It's multifarious. It has many perspectives or facets. It's multifaceted. That's probably the best term. Justice is multifaceted. It has many facets or perspectives. So let's look primarily at personal decision making. Here are some things that a doctor or nurse should do in order to promote and protect justice. First of all, Gillon says, and I'll quote him here, he says, I, the medical professional, must try to exclude decisions that have no moral basis or justification. So a doctor should not act on the basis of self-interest. Okay? That would be too narrow. That would be morally unjustified. A doctor should make decisions day in and day out that have a proper moral justification. So that rules out things like self-interest. It rules out things like prejudice. Don't be prejudiced against certain patients or individuals in your medical practice. Don't try to punish people for their behavior. Suppose you personally believe that smoking is stupid, and you, for that reason, have never smoked and maybe find it hard to understand why anybody would. Still, in spite of all that, you must keep that out of your medical practice. So if one of your patients is a heavy smoker, a lifelong smoker, and doesn't want to quit smoking, then you need to find a form of treatment that respects that. You can advise your patient to give up smoking, and a good doctor would do that. But you can't badger your patient, and you shouldn't refuse to treat someone just because he or she is a smoker, and that goes against your personal beliefs or values. So it's a fine line, isn't it? You've got to keep your own personal views about things like smoking out of your decision making as a medical professional. The same would be true for heavy drinkers. You may be a teetotaler or someone who abstains altogether from alcohol. Maybe you never had a drink in your life, but some of your patients will have health problems that are brought on by their own heavy drinking or even alcoholism. Still, you must not be prejudiced against them. You must find ways to treat them in the same way you would treat any other patient. Again, you can advise that the patient cut back on alcohol consumption or give it up altogether. And your advice should be based upon the facts. You should say that to the patient, for example, if you continue drinking at your current rate, you are highly likely to come down with the following ailments or diseases that would require some serious interventions, medical interventions. Okay, so the first thing you should do in your medical decision making is avoid any form of prejudice or self-interested conduct. Okay, that's what justice requires. Secondly, and I'm going to quote Gillon again here, he says, I should not waste the resources at my disposal. So when you waste scarce resources, you're acting in an unjust way. Justice requires that you respect the scarcity, that you allocate the scarce resources in a fair or just way to your patients. And any form of wastage of any scarce resource is unjust because you're depriving people who need and want that resource of it. So wastage is a no-no in the practice of medicine. That's a technical term, a no-no. And I'm just kidding about that. But seriously, doctors should not waste scarce medical resources. And that could involve everything from, the rubber gloves to machinery. Valuable machinery should not lie unused when there's a demand for it. That's a form of wastage. You're wasting the technology. It doesn't mean you're destroying it, but you're not making full use of it. So in effect, you're wasting it. It's a scarce resource. And all the other items in a typical doctor's office, the needles and anesthetics and so forth. Just don't waste anything. Okay. Also, Gillon mentions if you can prescribe 2 different drugs for the same ailment, one of them may be more expensive than the other. You should prescribe the cheaper drug rather than the more expensive one if the benefits are the same. And that's a form of avoiding wastage. Don't waste money on more expensive drugs when a cheaper drug does the same amount of good. Okay, third, we've already covered this one. I should respect patients' rights, Gillon says. He says, don't abuse certificates of sickness. Patients of doctors often ask them for an excuse, a doctor's excuse it's called, and doctors are usually more than happy to have those written and to sign those. But you should not, if you know that a patient is just trying to avoid work, you should not write a doctor's excuse for that person. Okay, these are called certificates of sickness. You should fill one out only when the circumstances demand it or require it. Okay, finally, I ought to obey morally acceptable laws. This is what we talked about a moment ago. This is another aspect of justice. And remember my point that I'm sure Gillon would say that if you violate a law because you sincerely believe that it's unjust, then you should be prepared to take punishment. Okay, on the other 3 perspectives, remember, The 4 perspectives are personal, organizational, professional, and societal. And all I have to say about the other 3, because Gillon doesn't say much about them, is that if you're part of an organization that has made a moral decision or judgment, you're bound to comply with that. As part of the organization, you have committed yourself to complying with that organization's decisions and decrees. You may well disagree with one or more of them. And if you do, you have every right to try to persuade your organization to change it. You may argue that it's misguided or wasteful or ineffective or unjust or unfair or simply morally wrong. You have every right to try to persuade. But short of that, you must obey those organizational directives or decisions. Okay, so you're entitled to participate in the process by which these decisions are made and revised. But once they're on the books, once they're in place, you ought to obey them. And that's part of what it means to be part of an organization, isn't it? That means you're committed to something larger than yourself, with its own rules, its own principles, its own decisions and policies. Okay, one more topic for today. Let's talk about scope. All of the principles that we've been discussing, respect for autonomy, beneficence, non-maleficence, and justice. All 4 of them have questions of scope. Scope has to do with how far they range. This would represent, let my fingers represent a circle. This would be small scope. The principle operates only within this small circle. This would represent large scope, or at least larger, and this would be larger still. So we have to decide the size of the circle in which the principle operates. And that calls for a moral judgment all by itself. We have to make determinations of scope. So let's go through the 4 principles and you'll see how this works. As far as healthcare goes, if we're looking only at the scope of these principles for healthcare, which is Gillon's topic in this article, if we're dealing with the principle of respect for autonomy, we have to decide to whom does it apply? How broadly or narrowly does it apply? Well, this one is pretty straightforward. Only autonomous persons or autonomous beings are included in the principle of respect for autonomy. But that raises some thorny questions. Gillon says, who or what counts as an autonomous agent? Would a girl who's 14 years old who wants an oral contraceptive pill, who comes to see you outside the scope of her parents' authority without her parents even knowing, are you to treat that 14-year-old girl as an autonomous agent? Are you to respect her autonomy? In fact, does she have autonomy? Is she an autonomous agent at all? If she's not, and I'm not saying she's not, I'm saying if it's determined that she's not autonomous, then of course the principle of respect for autonomy wouldn't even apply to her. Okay? The principle of respect for autonomy applies only to autonomous beings, autonomous agents. What about newborn babies? Are they covered by the principle of respect for autonomy? That one's pretty clearly no. Although the guardians or parents of newborn babies obviously are autonomous, and so you ought to respect their autonomy when you make decisions that affect the newborn baby. Okay? What about severely mentally ill or mentally impaired people? Are they sufficiently autonomous to be brought within the principle of respect for autonomy? You can see now that it's not always easy to apply this principle, because sometimes you have to make a preliminary judgment about whether the person in question or the being in question is autonomous. And keep in mind that competence is task relative. Autonomy is a set of competences, Right? An autonomous being is competent to make decisions about this, that, and many other things. But competence is relative to task. A particular person, let's say, who is mildly retarded, and that was the term up until recently that was used by medical professionals, judges, philosophers, and others. So I'm going to use it. A mildly retarded person may be competent to make many decisions in everyday life, but perhaps not competent to make a life-threatening decision that affects his or her life. Maybe the person is not competent to make that decision because of the gravity of it. How about a severely retarded individual? A severely retarded individual may be incompetent to make most decisions, but competent to make a few fairly harmless or innocuous decisions about what to eat or what clothes to wear. So if you have a severely retarded family member, you will find out what decisions that person is competent to make, and you will allow that person to make those decisions. What do you want to wear today? You want to wear shorts or long pants? What color shirt do you want to wear? What would you like to have for lunch today or dinner? What kind of ice cream do you want? And maybe, I don't mean to belittle the decision-making of severely retarded individuals, but maybe they're competent to make even more important decisions than those. I guess it depends on exactly the degree of retardation in the particular case. So when I say competence is relative, I mean some tasks are more important and riskier than others, and so different people will be competent to make different decisions. Okay, let's move on to beneficence. What's the scope of the principle of beneficence? Well, since we're talking about healthcare primarily, Gillon simply says, quote, all healthcare workers have a moral obligation to help their patients and clients. At a minimum, the principle of beneficence tells a doctor or a nurse, do good for your patients. Does it specify doing good for other people outside of the healthcare setting? Not necessarily, but remember, doctors and nurses, in addition to being doctors and nurses, are citizens. And as citizens, they have duties of beneficence like we all do. So it's kind of nested beneficence. A particular doctor has a duty of beneficence as a citizen and as a doctor. And the duty of beneficence that you have as a doctor is obviously toward your patients, right? Because of the doctor-patient relationship that you're in. You'll see me moving around. I'm sitting in a very rigid chair, and there's no give to it, so sometimes I need to stretch my back. Okay, what about non-maleficence? To whom? What's the scope of that principle? Here's what Gillon says, and then we'll say a few words about it. He says, we have prima facie moral obligations not to kill all people, but we have obligations to keep alive only some people. Now that's badly worded. He's saying, it sounds like he's saying our obligation is not to kill everyone. I think what he means is our obligation not to kill applies to everyone. Right? So it's not as though we have an obligation not to kill all people at once. What he's saying is we have an obligation to every individual person not to kill him or her. But we don't have an obligation to keep everyone alive. So non-maleficence means don't harm anyone. Keeping people alive by putting them on life support, for example, is an obligation we may have only to certain people. People who need a particular machine to stay alive, a ventilator, a heart-lung machine, kidney dialysis machine, or something like that. And what he's saying is we have a negative obligation not to kill that applies to everyone. We have a positive obligation to keep alive that applies only to a subset of everyone, only to those people who need it. So non-maleficence also has scope. And finally, justice. Here's Gillon. Who or what falls within the scope of our obligation to distribute scarce resources fairly according to the principle of justice? Is it everyone in the world? Future people? Just people in our own countries? This is the question of global justice. Philosophers sometimes focus on particular societies. When John Rawls, the great American philosopher, wrote his book, A Theory of Justice, in 1971, actually he wrote it for about 20 years up to that point. He published it in 1971, 50 years ago now, this year. It's a great book. It's very long, very difficult, but if you're interested in justice, you may want to pick it up and read it. It'll be worth your time. Anyway, in that book entitled A Theory of Justice, Rawls discusses justice within a particular society, a liberal democratic society like ours here in the United States. And many people criticized him because he didn't say much in that book about global justice, about justice between nations or between societies, the justice of the whole world. Right? His focus was on a particular society or nation state. And Rawls was sensitive to that criticism. Several years later, he wrote another book entitled The Law of Peoples. Peoples, plural. There are different peoples in the world. The peoples of Europe, the peoples of Asia, the peoples of South America, the peoples of North America. And in this book, Rawls finally took up the topic of global justice, a book about how scarce resources in the world should be distributed among peoples all over the world, not just in the United States or some particular country. So that's the question Gillon is raising here. Should we focus when we're allocating resources just within our own organization? Should we look at something larger than that? Should we look at society as a whole? Should we look at the whole world in a global, more cosmopolitan way? And that's a very hot topic these days, I can tell you. Global justice. Books and articles are pouring out on that topic. We live in an interconnected world now where all of our stock markets around the world are interconnected. Things that happen in China affect us. As you can see with the coronavirus, it originated, so far as we know, in China, and it spread very quickly to other parts of the world with devastating effect. So we live in an age in which diseases are global, not just local. The economy is a global economy. Mobility is higher than ever. People can move from one place in the world to another and still do the same work. So it's a very different world today than it was when I was your age, in the 1970s, let's say. And philosophers who are trying to stay on top of things are now using their philosophical skills to analyze this new world in which we live. It's quite exciting. If you decide to go into philosophy, maybe you'll make that your specialty and end up working in that field and writing books and articles with titles like Global Justice in Global Medicine or something like to that effect, or The Ethics of Pandemics. Okay, what's the conclusion of this article? And then we'll be done for the day. Gillon concludes as follows. The 4 principles plus scope approach enables healthcare workers from totally disparate cultures, moral cultures, to share a fairly basic common moral commitment, common moral language, and common analytical framework for reflecting on problems in healthcare ethics. So to Gillon, one of the main advantages of the 4 principles approach, which is disparagingly referred to by the critics of it as principalism, one of the main advantages, according to Gillon, is that it provides something common, something that can bind us together, people from all different walks of life, all different backgrounds, people of all different moral theoretical approaches, people of different political persuasions. It gives us a common framework to use to analyze moral issues that arise in healthcare and in the practice of medicine. And that's one of its main virtues. It's something that can bring us together in a world that is becoming more and more fractured and divided. Here's something, Gillon seems to be saying, that can unite us and bring us together. And that's not the least of its virtues, he would say. All right, I'm going to post another article by Raanan Gillon, the same author. He published it many years later, and it takes up some of the criticisms that have been made of this whole approach that he calls the four principles approach plus scope. And I'm going to put, when I post it on Canvas in the next couple of days, I'm going to put the words optional reading in the title of it. And that's to remind you that I won't be testing you on it. But I assume that at least some of you will be interested in following up on this and seeing what the criticisms of this approach have been and how Gillon responds to them. So it's entirely optional in the sense that I won't test you on it. But I hope you read it and think about it anyway. All right, enough for today. We're an hour and 6 minutes in. I finally caught up. Thanks for being patient. I had a lot of meetings and other personal things come up. I had a physical exam this past week, and I didn't lecture that day, so it set me back a day. But I'm caught up now. This lecture right here, once I get it posted, will bring us up to spring break, and I'm going to try to stay on track after spring break. I'll try to get my 4 lectures done each week by Friday. Remember, I have 2 courses, 2 lectures a week. That's 4 lectures per week, and I like to do no more than 1 lecture per day. So I'm going to try to get them all done between Monday and Friday. And because I don't like lecturing on weekends any more than you would like watching a lecture on a weekend. Okay, so that's enough for today. Have a great day and have a nice spring break, what's left of it, and I'll see you after the break ends.